So John O'Keefe, our Director of Knowledge Networks, asked me to create a clinical case for discussion. I posted this photo of tooth number 1-3 that's crowded out and misplaced to the buccal. I'd been asked to expose the tooth, attach a bracket and chain, and extract tooth number 1-4. There's little heavily keratinized tissue on the buccal aspect. You can see that it ends here and here. The debate has been that if tooth number 1-4 is extracted, will the tooth erupt naturally? And if it does, what are the chances of it developing recession? David, in the comments section, has pointed out an excellent review of the situation by Mita and Lim from 2010, where they discover that the risk of recession is generally quite low. One of the 4 exceptions to the risk they list, however, are buccally displaced teeth during ortho. In this case, I elected to complete a small rotational flap when the extraction, exposure, and bonding was completed. There are 2 basic flap types: pedicled flaps, where an artery runs down the middle of a flap, and random flaps, where there's the normal axial blood flow. This will be a random flap. Whenever you create a flap, the length of the flap shouldn't be any longer than 1.5 times the width of the base. Otherwise, the distal end of the flap can necrose, which is where you suture, so the wound will blow apart. When the blood supply is more precarious, you might want to stick to 1:1, and where it's a little richer, you can go up to 1:2. My plan was to make an incision along the black line, where the distal flap is rotated and advanced medially, and the medial flap is rotated and advanced distally. The minimally keratinized middle part is deepithelialized and sewn together in the buccal vestibule, well away from the tooth. Ideally, the distal flap would have come all the way to the mesial of the tooth, but I didn't think the blood supply would support it. As far as the beds that are left from the flaps, I decided to let the distal one granulate in, since there was keratinized tissue on either side of it, and advance a bit of the loose vestibular tissue to cover the medial bed. This is how the flap looked when it was raised, and all sewn up with a bracket and placed at the end of surgery. Thank you for joining us at JCDA Blogs. I'm Ian First from Coronation Dental Specialty Group in Southwestern Ontario.